All right, nursing students, welcome. In this high-yield review, we're going to walk through the entire perioperative journey. We're talking from the second a patient decides on surgery all the way through their recovery in the PACU. This isn't just about memorizing facts for your exam. It's about building a solid mental map that's going to help you think on your feet and prioritize when things get intense.
So, here's our game plan. We're going to follow our patient's story through 5 key phases. First, the super important prep work before surgery. Then, we'll go inside the OR. After that, the vulnerable handoff to the PACU. We'll also cover how to spot and manage dangerous complications. And finally, we'll hit the must-know drugs that you'll see all the time. Okay, our journey starts right here in the preoperative phase. Everything that happens in these hours before surgery sets the foundation for what comes next. This is our time to shine, where we as nurses catch those little problems before they blow up into total catastrophes. To get our brains warmed up, let's start with a real gut check question. Picture this. You're doing your final pre-op check. What's the one thing, just one finding, that would make you immediately pick up the phone and say, "Hold everything, stop the surgery"? Keep that question in the back of your mind as we move forward.
Before anything else, we have to talk about consent. And here's the deal. Consent is so much more than just a signature on a form. It's a whole process built on 3 pillars that you absolutely cannot skip. The surgeon has to disclose everything. The patient has to actually understand it, and they have to agree to it on their own without pressure. Our job is to witness that signature, sure, but more importantly, we are that patient's last line of defense. If they seem confused or you think they don't get the risks before they get any sedatives, you have to speak up. You have to stop the line.
Now, look at this table. These numbers, they're not just numbers. They're telling you a story about what's going on inside your patient. A potassium level that's off even a little bit is a massive red flag for life-threatening heart rhythm problems once anesthesia hits. High creatinine? That tells you the kidneys aren't working right, which means the anesthetic drugs are going to hang around way too long. Knowing these red flags isn't just for an exam. This is fundamental to keeping your patient safe.
All right, pre-op checks are done, consent is solid, labs look good. Our patient is now heading into the OR. This is a whole different world of sterility, technology, and teamwork. And the nurse's role here is absolutely pivotal.
You've really got to get the difference between these 2 types of anesthesia because it totally changes what you're looking for post-op. With general anesthesia, the patient is completely unconscious, no protective reflexes. So what's your number one worry afterward? Their airway and their breathing? For sure. Now, with a regional block, they're awake, just numb in one area. That usually means a faster recovery, but now your focus is on checking for the return of feeling and movement.
In the OR, think of the circulating nurse as the patient's guardian angel. Seriously, while the surgeons are zoned in on one tiny part of the body, you have the 30,000-foot view. You're watching the whole patient, the whole environment. You're doing everything from making sure the grounding pad is on right to prevent a nasty burn, to leading that critical timeout to make damn sure you have the right patient, the right surgery, and the right site. Your job as an advocate does not stop when they fall asleep.
Okay, the surgery's done, but listen, don't relax yet. This next phase is honestly probably the most critical part of the entire journey. The patient is just starting to wake up, their vitals can be all over the place, and that handoff report from anesthesia to you, the PACU nurse, has to be absolutely perfect. I don't care what else is going on. I don't care if the surgery was for a hangnail or a heart transplant. Your first thought, your first action, your first assessment in the PACU is always, always, always ABCs. Airway patent, breathing effectively, circulation stable. Nothing else matters until you know the ABCs are solid. So why are we so obsessed with breathing? This chart right here shows you exactly why. After anesthesia, that normal, easy breath a patient takes, their tidal volume, can get really, really shallow. And that leads directly to parts of the lung collapsing and oxygen levels dropping. Understanding what normal breathing looks like helps you spot right away when a patient's just not moving enough air and needs help.
The arterial blood gas, the ABG. I know they can look super intimidating, but trust me, it's just a simple 3-step process. First, just look at the pH. Is the blood acid or alkaline? Simple. Second, find out why. Is it a breathing problem with high CO2 because they're not breathing enough? Or is it a metabolic issue? And third, check for compensation. Is the body trying to fix itself? A classic post-op finding is respiratory acidosis, all because the patient is still too sleepy to breathe off that CO2. Look, even with the best care in the world, complications are going to happen.
The key to a good outcome isn't just trying to prevent them, it's recognizing them the second they start and jumping in to fix it. This is where that scary term, failure to rescue, comes into play, and it's where a sharp nurse makes all the difference. These right here, these are your fire alarms. These are the bright flashing red lights telling you your patient is in trouble. When a patient's breathing rate creeps up over 30, or their heart rate suddenly jumps to 140, or their urine output just stops, that patient is screaming for help. These aren't just numbers to chart, they are urgent calls to action. You have to figure out why, and you have to intervene now. You have to remember, surgery is a massive physical stressor. It puts a huge strain on the heart, and that's why acute coronary syndrome is such a major post-op risk. ACS is just an umbrella term, right? It covers everything from that warning sign of unstable angina all the way to a full-blown heart attack, a myocardial infarction. So if you suspect your patient is having an MI, what labs are you looking for? Okay, troponin. That's your gold standard. It is the most specific and sensitive marker for heart muscle damage, and the best part is it stays elevated for days. Now, CKMB is useful too, but it washes out of the system much faster. And that actually makes it really helpful if you're trying to figure out if the patient had a second heart attack right after the first one. Now, let's switch gears and talk about some special cases. If you have a patient who just had eye surgery, your entire goal is to reduce pressure and movement. That means bed rest, limiting activity, and even telling them not to read. For a patient who had ear surgery, the big enemy is anything that increases pressure inside the ear. You have to teach them, do not cough, do not sneeze, do not bend over or strain. It could totally ruin the delicate work the surgeon just did. And last, but definitely not least, let's dive into pharmacology. You can't be a great perioperative nurse without knowing your meds cold. They're part of every single phase of this journey we've been talking about. Whenever you see a diuretic on a medication list, I want one word to flash in your brain: potassium. Furosemide, that's a loop diuretic, is super powerful, but it makes the body waste potassium, which puts the patient at huge risk for hypokalemia. On the other hand, spironolactone is potassium sparing. It actually makes the body hold on to potassium, creating a risk for hyperkalemia. Getting this wrong is a life-threatening mistake, so you have to know the difference. And then we have the beta blockers. You know, all the drugs that end in olol. They're absolute workhorses for taking stress off the heart. But man, you have to be so careful with them. You must check the heart rate and blood pressure before you give them. The classic rule is to hold if that heart rate is below 60. And this is crucial, you can never, ever stop them suddenly. Doing that can cause a massive rebound effect and trigger the exact heart attack you were trying to prevent. So to bring this all home, I want to leave you with a question to really think about. We've walked through this whole journey together, so where does it all go wrong? Where does failure to rescue actually begin? Is it that tiny assessment finding you missed before surgery? Is it a small break in sterile technique in the OR? Or is it waiting just 5 minutes too long to react to a changing vital sign in the PACU? The truth is, it can happen at any of these steps. Your watchfulness, your critical thinking, and your courage to speak up for your patient, that is what saves lives. Good luck on your exam.